Hello, I would like to review with you aspects of this decision-making flow chart, especially the aspects that pertain to the right side. Now, the key question to begin with when facing medical decisions for patients is, does the patient have decision-making capacity? Now, it's either going to be yes or no. If they do have decision-making capacity, then of course we want to encourage patients to exercise their right to informed consent, and in the case that patients are minors, to enable them to give their assent for treatment. So I want to set aside the left side of the flowchart for now and concentrate more on this right side, which introduces a whole level of complexity in the case that the patient does not have decision-making capacity. So if the patient does not currently have decision-making capacity at the time in which medical decisions and treatment have to begin, then first we would have to ask, did the patient once have capacity and now lost it? Or is this a patient that's either too young or never had capacity to begin with? So in the right side of the flow chart, we actually have not one, but two standards for surrogate decision making. Surrogate decision making is decision making for cases where patients do not have capacity and others, i.e., surrogates, have to make that decision for them. So when they don't have capacity because they either are too young or they are mentally disabled and they never had capacity, then we do have to use what is called the best interest standard. And the best interest standard is basically weighing the pros and cons of treatment, but not the pros and cons strictly on a medical or physiological or physical basis, but also we might want to weigh the pros and cons for that patient individual regarding their psychological, emotional, and even in some cases their social well-being. This is done by others who are well-intentioned and who want to and need to take care of the patient. Now, if the patient does have capacity and they actually had capacity but now lost it, in cases like this, hopefully the patient's wishes before they lost capacity are known either through a living will or through a healthcare proxy that the patient has designated, or more informally in some states, if there's no legal designation, that there's a family member available to serve as that proxy. Now, one of the two standards for surrogate decision making we already mentioned is the best interest standard, but the situation where the patient had capacity but now lost it introduces the possibility of another standard of surrogate decision making called substituted judgment. So we'll talk about how we get down to there. In cases where they lost capacity, sometimes, unfortunately, there is nobody available to help in the decision making, no family member, no friend, nobody there accompanying the patient who doesn't have capacity, and moreover, there's no living will to help. So in those cases, like we had to do for the young child or the person who never had capacity, you have to use a best interest standard. So actually, there are two occasions where you may have to use a best interest standard, and they relate to the two boxes there. But more interestingly, if they do have, and more commonly, if they do have somebody who can speak on behalf of the patient, then we introduce another standard for surrogate decision making called substituted judgment. And there, the surrogate is supposed to channel the patient's wishes. If there's a track record of values and conversations that the patient had with others that give you clues about what kind of treatment choice they would have wanted under the circumstances, then the surrogate needs to substitute into their own minds the judgment of that patient and speak for that patient, to be that patient's mouthpiece. The living will is yet another way to employ surrogate decision making, namely the written instructions of the patient. But the living will is quite more limited than the proxy directive because living wills are normally only initiated when there's a terminal diagnosis for the incompetent patient or when they're facing the possibility of persistent vegetative state. So proxy directives will actually be a little bit more flexible and will be more useful in lots of other circumstances where treatment decisions have to be made for patients who have lost capacity. So we have here two standards for surrogate decision making, the best interest standard and substituted judgment. And you see that you really end up in this flowchart regarding substituted judgment just in those cases where you have people available to speak for the patient. In all other cases, we do unfortunately have to use the best interest standard. And so hopefully this will help you organize your thinking about what standards of surrogate decision making we use and at what time. Thank you.